Welcome to The Remedy, brought to you by NYC Health and Hospitals, innovating public health care to benefit all New Yorkers.
Hey everyone, it's Dr. Michael Shen. Welcome back to The Remedy. Today we'll be discussing the impact of gun violence in New York City and the groundbreaking work happening at NYC Health and Hospitals through our hospital violence interruption programs. In New York City, nearly 66,000 children live in neighborhoods with chronic exposure to gun violence. And our public hospitals see thousands of patients each year for violent trauma that disproportionately affects Black and Latinx communities. Our hospital violence interruption programs, made of diverse community organizations, as well as NYC Health and Hospital staff, operate under a simple philosophy that gun violence is a public health crisis and should be treated as such. The programs are based at 5 of our public hospitals and led by incredible teams of emergency room physicians, nurses, social workers, and most importantly, community members with lived experience. They begin their work at the victim's bedside during some of their most vulnerable moments. Today, we're coming to you from NYC Health and Hospitals Kings County here in Brooklyn, and I'm joined by 3 leaders in this effort: Dr. Rob Gore, attending emergency physician at NYC Health and Hospitals Kings County, and founder of Kings Against Violence Initiative, known as CAVI. We're also joined by Mr. Yahsef Johnson, Hospital Program Coordinator for CAVI, and Mr. James Dobbins, Executive Director of Guns Down, Life Up at NYC Health and Hospitals Lincoln in the Bronx. They'll share how their programs are transforming victims' lives and working to not just treat violence, but to prevent it. Dr. Gore, Yahsef, and James, welcome to the show.
Thanks for having us.
So I want to first give our audience a sense of your backgrounds and how you came to be in this work. Dr. Gore, I want to start with you because I just had the pleasure of reading your book, Treating Violence. And in it, you talk about your upbringing in this community in Bed-Stuy. Can you tell us a little bit about how you became an ER doctor and got into this work?
I think that's a great question, Dr. Shen. I come from a family of activists and changers. I grew up in Brooklyn, in pre-gentrified downtown Brooklyn and in Flatbush, and spent some childhood in Bedford-Stuyvesant, not too far from where we live right now. But when you look around the neighborhood that you live in, you realize that there's certain things that you notice when you're in other parts of the city. We know that there are differences in what people look like when you're on the Upper East Side of Manhattan and compared to when you're in downtown Brooklyn. And figuring out when you have somebody who's coming in with an injury or an illness and it's completely preventable in certain places, you ask yourself these questions: why does this keep happening to people in my respective community? Why is this happening to my family members? And why is this happening in ways that people just don't seem to care? I think a lot of people, you did some of your training in the public hospital system here in New York City and spent time in the private hospital. You know that there's a very, very fine line between who does well and who doesn't. But there are some people who come and practice in our respective hospitals purely say, I want to go to the county. I want to go to Lincoln. I want to go to Jacoby. I want to go to Cook. I want to go to LA County. And because I want the experience, I want all the gore. No pun intended with my last name, but you want all of that stuff so you can get experience, but then you leave. Dr. Charles Drew, who's famous, famous blood plasma pioneer, said something to the likes of, you need to go where you're needed most to bring the knowledge and the skill sets that you've acquired back to the places that have nurtured you. So me coming back to Brooklyn and practicing in my respective communities, really kind of living out some of those statements that Dr. Drew mentioned, the stuff that my parents talked about, coming back to the community, making sure that you provide some sort of support so that people's lives wind up improving and benefiting from your very presence.
Yahsef, I want to turn to you and ask you about what inspired you to be part of this work.
Thank you for having me. Similar to Dr. Gore, right? Born and bred in Brooklyn. I first came to this work thinking that it was going to be very easy because I've lived those experiences myself. I came from Coney Island, born and raised, and probably seen my first shooting before the age of 10, right? And so what that looks like being on the ground is being inundated with these things on a regular basis and not seeing like the impact that it has on you regularly. So It wasn't until one of my mentors, is someone that Dr. Gordon knows, Dr. Ramon Gist, who brought me onto this space of public health. Right, I told him that like I had previous aspirations of being a doctor, of being a healer in that sort of way. And then he's like, "Hey, why not try to do a public health degree?" And with that sort of like encouragement, I was able to complete my MPH, actually right across the street at Downstate, SUNY Downstate Medical Center. Um, and it wasn't until I had that sort of like that experience that I saw that I was so impacted by what's going on, the ins and outs of the city of New York and in Brooklyn, right? So like I have a sibling who has been impacted by or suffers from a bipolar disorder. I have another sibling who suffers from schizophrenia, and so like I remember seeing those play out as a young person, right? And how that escalated to something that happened in the household, to then escalate to violence in the school, to then escalate to maybe going to jail, right? And so being directly impacted, seeing that in the household, really gave me like another lens in trying to do this work currently.
It's really great that you've accomplished your goal of becoming a healer, and basing a lot of that on your own experiences, your personal experiences. Thank you. James, what about you?
Yes, thanks for asking. That's interesting. So, my name is James Dobbins. I'm the executive director, New York City Health and Hospital, Lincoln. So when I was 6 years old, my aunt was murdered by my uncle, by gun violence. So at a very early age, we was affected by gun violence.
Mm.
And my mother took in her 3 siblings. So everyone in the block was, what's going on? What happened? So we had to explain how my aunt was murdered by my uncle. And it was just a real awkward situation, having gun violence. And then there was talks of retaliation with my uncles. But that was the first time I was really impacted by gun violence with my family members. And to this day, my mother talks about how she's traumatized and, and how it just changed our lives. So fast forward, when I was, brought this situation, Guns Down Life Up, I was involved from its inception. So actually, Marley Marl came up with the slogan, Guns Down Life Up, and the logo. It's supposed to be the unfinished edges. I want to show this popular shirt here. So the unfinished edge is supposed to be New York City, but we decided to keep it edgy and cool to promote peace. So we wanted a brand that kind of speaks to you, mention the initiatives, and we wanted to make it cool and trendy. So it started out me just testing the brand to see how people embraced it. Then we learned that it had no boundaries. We could give it to a 2-year-old, to a 90-year-old, that it had no boundaries. We would give it to the at-risk or high-risk youth. Then we would give it to an elected official. It had no boundaries. And that really made me, when I realized that I can make a difference in my past experiences, all my friends and peers being affected by gun violence, myself being affected by gun violence, my past experiences, as we'll talk later on, how I've been incarcerated and how I came home and how I didn't have certain resources. This would really made me mold the program at Lincoln Hospital, because I looked at what would I say to myself, or what did I need when I was going through these situations, or what did my friends need? So this is what really motivated me to really make a difference.
And James, you mentioned this term retaliatory violence, and in all of your answers, I think I'm picking up on this idea that violence is a cycle, and a lot of this work revolves around thinking of violence as a preventable public health concern. Yahsef, I wanted to turn to you and ask a little bit about the on-the-ground work and what that actually looks like when you take that concept and bring it directly to the patient.
When someone comes in for a gunshot wound or a stab wound or an assault, the hospital gives us the space and the infrastructure to respond in the moment at the bedside. The benefit of that is you get that rapport building with a term that has been coined in the space, that golden hour of trauma, right? That way, because they are really at that moment of how do I change? How do I get myself out of the situation that led me to the hospital? this is our opportunity to have folks on the ground to really speak truth to power in that sense.
There's one thing I actually want to piggyback that I know the CAVI team does and all the respective programs do. It's not just treating the patient who's been the recipient of violence, it's the entire family. You're familiar, you're a primary care physician and you understand probably better than most docs what these different support systems look like that can enhance the well-being of the patients. We look at social determinants of health, and one key thing is the social support system. So the family, the school, the community that surrounds them. And so when one thing happens to one person, everybody gets impacted by it. And so it's important that our team members meet with the person who's the patient. And sometimes if the person has to go up to the operating room, if they're considered to be unstable, if they got to go to the ICU, or if they can't speak, you can't talk to that person directly. Right? And so you then focus on who that support system is and who's also a very vulnerable member of that immediate community. And that might be the parents, it might be the sister, it might be the significant other. And it's really almost a community approach to medicine.
If somebody gets shot, stabbed, or injured in the community, right? The ambulance come for the patient, the police come to crime scene, but who comes for that young man who wants to retaliate? Who comes for the community that's traumatized? So that's the important void that we fill. Also, doctors and nurses, they do a great job patching them up, making sure they're okay. But who does that aftercare once they're released? We see these individuals in the corner store. We hire what we call credible messengers. I'm going to get into that later on, people who once lived and walked those experiences. So they do a great job patching them up, but that aftercare is important. That healing is important after they're released from the hospital. And 50% of the patients come back within 4 or 5 years. 20% of them don't make it. This is why this work is so important as to why we need to be in front of these patients by their bedside. So that alone is the reasons why this work is important. And when we talk about retaliation and credible messengers doing this work.
Paint me a picture of what feelings are in the room at that point, at that moment where you're going to engage somebody at the bedside.
There's two different things. It's almost like I have two different parts of my brain that are operating at the same time. There's the very analytical, looking at how do I keep this person alive? What are my ABCs intact? Am I maintaining the airway, breathing, circulation, disability, exposure? Because I got to keep this person alive. But then there's the other aspect. I'm like, wow, this is a person that looks like me. This is a person that comes from my block. Because I've taken care of people who live on my block who've been patients. I've taken care of their offspring or their cousins. These are people we've seen out in the community. So you have these emotional connections to people as well, and then they recognize you. It's this weird juxtaposition. You're being pulled in two different directions at the same time, but you also recognize that I need to make sure that I have to be present, and so just the practice of mindfulness becomes important in that space, and making sure that I can show compassion. Because who cares if you can analyze, and you do need to keep this person alive. But if the person isn't receptive to what it is that you're offering because they're triggered, they're scared, they're absolutely terrified, and you're not speaking to those triggers, those triggering events, or their prior experiences that they've undergone, if you're not speaking the language that they understand, using the slang that they usually understand, and saying, look, I understand that you've gone through a very painful situation. I know you're uncomfortable. Let me focus on things that are important for you. And then we can focus on some of the things that are important for us as clinicians. And so I think that these are some of the things, the conversations that many of us have as a part of that dialogue. But it's gut-wrenching to go through that experience and analyzing and systematically trying to treat a person's physical injuries. And then a few minutes later, because we may have lost the person, you have to go out and talk to the family members. And then more family members come in, and more family members come in, and more friends come in. You're having the same conversation. A lot of times people don't often consider that us as providers, us as intervention team members have our own prior triggers. And there needs to be a level of respite and recovery when you wind up doing this work so that you don't wind up becoming the patient. And this is something that I experienced when my mentee Willis was killed. The day Willis Young was an amazing person. He was one of the first hirees within the entire Health and Hospitals Corporation to do violence intervention work. And he was a violence intervention specialist for CAVI, meaning that he did all the work that James and Yahsef were describing in terms of intervening and being credible messengers. But on my birthday in 2015, Willis, I got a phone call. My morning wake-up call was that Willis was stabbed multiple times and was brought to the emergency department in critical condition. Then he went to the operating room, had multiple surgeries, and was hanging on for a couple of weeks. but then he died from infection. Willis was probably stabbed like maybe 9 or 10 times all over his entire body. After, there's a period of time where when everyone mourns, and then we have the funeral. The night of his funeral, I never slept at all. I'm going, and I'm running off of fumes. I'm running off of really a fight or flight. So I'm stuck in this fight or flight sympathetic nervous system like state, and I'm not functioning. I'm not relaxing at all. And the night of his funeral, I took care of another person who was shot multiple times, but I happened to know them because I took care of his little brother who was shot and killed by the New York Police Department. And the mother recognized me when she asked me some questions about the son who had passed away. In addition to the son who was still alive, my body broke. I started having palpitations. I'm crying. I'm dry heaving. And I'm still working. I'm working in our critical care and trauma emergency department. But now all of a sudden I'm having panic attacks. And how do you, as the person who's in control, who's supposed to be helping keeping people alive, what happens when you've now become the patient? And so I think, as a part of this work, Jimbo knew Willis. Yahsef didn't know Willis, but he knows of his spirit and knows of the legacy. Right. But I think it's really essential as a part of this conversation that although it's essential that we do this work and we provide a great service, there also needs to be levels of support for people doing this intervention work.
Yeah, seeing so much trauma can be very traumatizing itself, right?
Yes, so I guess this is a good segue to why we swim upstream, why we have our prevention component, giving people positive things to do during their idle time. So here at Lincoln Hospital, we provide, we do fun things. We do music, media, fashion, dance. But meanwhile, when they're in the studio, then they're learning Pro Tools, they're becoming engineers. When we talk about fashion, they're creating concepts and T-shirts, but meanwhile, they're learning account receivable and account payable. So we kind of use these things as a carrot, as a bait, to kind of engage them. Then we have a space at Lincoln Hospital, the Lincoln Hospital provider. So the intervention is one component, dealing with the family support and making sure the patients, we offer them alternatives and resources. But the prevention part is very important. All year-round employment. We have our anti-gun violent employment program, our Work, Learn, and Grow. Just engaging them and lining them up with mentors, being there for them, in real time. There's no shortcut in mentoring. Your phone is 24 hours. And just giving them that positive things to do during that idle time, during that after school hours is what we do as well. And then our third component, which is community mobilization, going into the community, bringing awareness.
You're not just doing these after school programs. These are tangible skill sets that translate into economic opportunities in the future. So even though we call it prevention, this is job training on all different levels that you've been doing an amazing job doing.
Thank you.
Yeah.
We have over 80 youth right now that's employed right now from our anti-gun violent employment program. So we're able to offer these things as prevention because we always talk about the problems, but what about the solutions? So we tend to be solution-based.
And it sounds like a lot of this is like kind of the long-term journey as well. You're thinking about the future of the people that you're affecting. Yahsef, I wanted to ask you about similarities or differences with the CAVI program and what you guys do with the community members that you work with.
Long term, we're doing the same thing. We're trying to figure out where we can work, what this person can work, what job skills they might have to complement wherever they want to go. So we've had actually a few people actually start employment at Kings County after being affected by or impacted by violence. The unfortunate part is the recovery process doesn't start after getting a job or successfully getting a job. The process is ongoing for the rest of their lives. Because you understand that folks don't have the opportunity to move out of the space that they were accosted, right? So now they have to go back to that corner store. They have to go back to that school. They have to go back to the block, right? And so it's really just like, how do you make sure you feel safe when you are impacted by violence in that space?
One thing I kind of want to add to Yahsef's comments is our school program. So the school program was actually the first program that we developed, and it was created. We were trying to set up hospital-based interventions for a number of years at Kings County, but then we had an idea and said, why do we have to wait for people to become patients? And everybody in and around this community is impacted by violence. Anybody in central Brooklyn, whether you're affiliated or non-affiliated, just the simple fact that you live and breathe and walk down these streets means that you have come in contact with some sort of violence. And we began our programming at the school right across the street from here at the Wingate High School campus, and worked with a number of the different schools within that campus with kids who were high risk. And these are kids who had histories of frequent fighting and doing poorly in school. Some were gang members. Some had gang affiliations. A lot of people have affiliations. Even if you're a high-performing kid, just because of your neighborhood, you have to have affiliation because you need to know people. And you need to make sure that you can get to and from school in a protected way. But that still leaves people that are very vulnerable in places that they need to be able to process that. And so our school program, we've had a few hundred kids actually more than a few hundred kids. We've been doing our school program since 2011, and we've had hundreds of kids, probably thousands over now, who participate in our school-based program. And we have an entire curriculum that goes throughout the school year during the school day, focusing on mediation and conflict resolution and a lot of life skills development, because we want kids to have practical and tangible skill sets that they can take with them outside the confines of that school. Kids in our school programs are now employed by CAVI. They do intervention work. There's some kids in our school program who've gone on to medical school, who've gone on to professional school. There's kids in the school program who are employees by Kings County Hospital. So we know that it's working.
Yes, and just to add a little, with the schools, just having we're part of Project Pivot, where we also go into the schools, where we have a presence in the hallways, a presence, wrap vehicles, our promotional vehicles in front of the schools. Also the courthouses, we get referrals from the Department of Probation, via our re-entry program. There's thousands of people that's coming home from prison. Where are they coming to? Where are they going? How are they prepared? Or do they have job readiness? And also just to go back into the schools, we want to catch them while they're early. So we have book readings. We have from pre-K to 5 years old, put it into their psyche.
You wrote this book, James?
Yeah, so this is the book that I wrote, A Safe Place to Grow. It kind of, Jordan, he overhears some of the adults speaking about the problems in the community. And he just talk about how can they engage the youth in positive. It explains what we do in our program through music and through podcasts. We also partnered up with the writer of Sesame Street, A Gun Is Not Fun. We're doing book readings in our adolescent clinic at Lincoln Hospital. We plan on doing book readings to put it into the youth psyche. It's a whole holistic approach. And we have to get them while they're young. So that's part of the solution, changing the mindset of these individuals while they're young and put into their psyche that a gun is hot. Or what do you do when when someone shows you a gun? Unfortunately, people have the rights to bear arms. And where do they keep it? In their house. It's just stored safely. So we just, in the schools, we just talk about all these things when we go into the schools. And we have so many success stories. We have gunshot victims. I can name like Z, who's been shot, who's a victim of gun violence. He's now employed by us as a hospital responder. He liked the way we stopped him at his bedside, talked to him to stop retaliation. We also have young individual, Isaiah. He was 14 years old. He was bullied in school. He was referred from our child psychiatry department, but now he's an employee at Lincoln Hospital. He's 21 years old and he works with us. So we have a lot of success stories and a lot of people that's been a part of our program that now part of the solution with us.
And I think that's really intentional. It's intentional to bring in people who have either had the lived experience or have been just as impacted, because again, they have the language that's going to reverberate to that particular individual.
James, I was wondering if you could tell us more about the outcomes that you've seen at Guns Down Life Up in Lincoln and the Bronx.
So I was involved with Guns Down Life Up from its inception. At Lincoln Hospital, 2017 is when we started our program. And in our catchment area, the stats, we cover Patterson and we cover Mitchells. We all have an assigned area that we canvass and cover. So inside our catchment area, the gunshots has gone down, I believe like 40% of the gunshots have gone down. But in our surrounding catchment area, because we are the busiest single-site trauma center in New York, or number 3 in the nation. So the stats have gone down since we've been hitting the canvas. And we've noticed a lot of incidents have been occurring outside our catchment. This is why we need more support and more funding so we could deploy more people externally outside our catchment area, because we see so much success in the areas that we cover and impact.
I want to ask a little bit about our broader system as well. Dr. Gore, NYC Health and Hospitals has 5 hospital violence interruption programs. I wanted to see if you could explain, why it's important to have this kind of system-wide approach that touches different communities.
The hospitals service specific communities. Every community has their own specific needs. We know that trauma can be so many different things. Unfortunately, I think many people only focus on the gun issue. And I think guns are an actual tool that carry out traumatic experiences. But like I mentioned before, my mentee Willis was stabbed multiple times. I've seen people who've been beaten to death with sticks and baseball bats. But I think having these individual programs, not every hospital is going to have the same kind of gun violence that's going to be coming to it, or the same kind of penetrating trauma. It doesn't mean that people aren't experiencing violence. And when somebody's been traumatized with one thing, it increases the likelihood of them using other tools to carry out future trauma, because people who are hurt tend to hurt other people. Having a system-wide approach means that we are able to share information, we're able to share best practices, we're able to share resources, we're able to really grow movements because there's strength in numbers. So there are 5 hospitals that have programs. Every single H&H institution, every single H&H clinic should have some sort of violence intervention program that's affiliated with it. It doesn't always have to be the same. It doesn't have to be a hospital-bred program, but it should be a community tie. Because what happened, we've spoken a little bit earlier, when people leave the hospital, they're going to go back out into the community. So it's essential that as a part of these efforts, tackling social determinants, we have to make sure that there are comprehensive community support systems. And what better way than our community hospitals, as well as our major hospitals, to have access to the resources that allow our patients to do well and be healthy and at their best.
I feel all the hospitals should have intervention, but the hospitals that don't have too many gunshots, or let's say too many incidences, we still should have prevention. Catching them before they get into the ER, doing outreach, offering them, connecting them to career paths. And the hospital is such a great safe haven where people come for healing. It's a place where it's been proven that the parents feel safe where their kids could come because there's cameras there and everything. So I just want to add that just having the hospital being that hub and us connecting with each other system-wide, because there's different trends that happen, like different things happen in Queens that happen in Brooklyn, and we're able to talk to each other to see the pattern. Like, for example, we learned that the construction, the scaffolding in different areas, we noticed there's a pattern where people may stash certain things or hide different things. And we say, hey, wait a minute, let's call these contractors to see how we could get these scaffoldings put down. Or there's areas where it's dark in areas, and when we need lighting in more areas. So we have what we call a community circle of safety meeting, where once a month where we convene and we discuss with all our stakeholders some of the problems, some of the solutions that's happening in the community. And this is where all our hospitals come. We come and convene and talk about the trends. So it's very important system-wide that we move as a unit, and we discuss and we spread this model. And the hospitals, to me, is a great platform because it's strategically placed in all our inner cities locations. And it's a perfect place. It's a safe haven.
One thing too, New York City, many people live and work in different parts of the city. So we'll have patients that we treat down here, but they live in the Bronx.
Right.
Or they live in Queens.
Yeah, exactly.
Or they live in Staten Island in some cases.
Right.
Or New Jersey.
Or New Jersey. And you've got to make sure that you have this access to this network. So like, look, I got a kid who got shot here in Brooklyn because he goes to school downtown Brooklyn, or he used to live here and then he moved out to the Bronx and they didn't want to take him out of his school here, but he got shot in the train station. And so we're concerned about his safety. We know he's going to go back up to the Bronx, but he had some words with some other people over there. So we need to make sure we get him in some sort of program so people can check on him on a regular basis. And so having that multidisciplinary network, very similar to what we as emergency physicians, if we don't have the resources to take care of somebody here, we transfer them to Bellevue. Or if we have somebody who's been in a burn, we transfer them to Jacoby Hospital, or we transfer them to, what's the other one? Cornell. In some cases, Staten Island, or we transfer people to Maimonides. It doesn't have to just be an H&H thing. It has to be who has the resource accessibility, who is a willing participant, and who's willing to provide that service, and who can do that in a timely fashion. We speak about golden hours of trauma. There are two golden hours. It's the golden hour to keep people alive after they've been involved in a major traumatic event. And there's that second golden hour, and that's the golden hour for intervention. Intervention you need to have that same level of accessibility to resources from the intervention component, but people like to poo-poo it and push it to the side because it's not sexy, because you're talking about preventative care, because it's cheaper. People are willing to spend thousands and millions and billions of dollars on emergency care, but they're not willing to do the same thing for primary care or prevention.
So also, how we get our funding. We're saving lives here. We shouldn't have to apply every year or hope with elected officials in office. It shouldn't be based on these things. We should be able to find the funding to fund these programs. I shouldn't have to worry about this I should be 20 years in advance funding. That way we don't have to worry about our funding streams. And we need to replicate these models that's been working. I mean, I'm so honored to be here next to Dr. Robert Gore. He has an excellent book. I mentioned it in the book. In the model and everything that we need to replicate. And I've taken pieces of his model as far as going into the schools, being mentors. So we learn from each other. And some of our practices came from Dr. Gore himself, and he inspired me. He motivated me to actually continue this work. So I'm saying that to say this is something that should be funded. We should replicate these models throughout the whole New York City health and hospital system, prevention and intervention. And we shouldn't rely on grants or rely on relationships with elected officials or who's godfathered in.
There's so many different people who do this incredible work around the city, and because of how their funding streams come, people have had to go into furlough and stop providing resources for intervention people. You can't stop a treatment. If you had somebody who had cancer and you said, "Oh, well, sorry, there's no money here. I got to stop your cancer treatment right then," and it's something that's working, or somebody's in critical condition, it's like, how do you withdraw support for somebody who's in critical condition and you're seeing improvements? And so this has to be, from talking about this work, the reason why we have these books, Treating Violence, A Safe Place to Grow. These are actual templates that we know that people who are legislative officials can go out and use as talking points to go out and seek longer term funding so that these movements continuously stay alive. We've been fortunate; we haven't had to stop funding we haven't had to fire people or put people in furlough, but some of our partnering organizations have. And when you have a team of 5 to 10 people and then it goes down to 1, that's a problem, because if anything happened like that in one of the hospitals, they would implode. And so why would you do something and remove funding and remove support away from something that that's working just to kind of watch things implode? So this is a political thing. This is a human thing. This is a human right. These are human rights violations that we're trying to make sure that we address. And if we don't address these things head on, they will continue to happen over and over again.
There's a need, there's a community need, there's a societal need for this work. But I wanted to end with a question for all of you, which is, what brings you joy during your daily work in this area, in an area so filled with violence and trauma? What's the best part of your day?
The smile, when they're working for the health and hospital that didn't have a job, someone that lived in the shelter now they're able to take their pay stub and show and and have stable housing, that have housing now.
Yeah.
To see that person who come home from prison, and now is working. A person that's a gunshot victim that now works with us and help others. It's amazing. This is what keeps me going. Because again, I didn't have these resources. To see a family member, sadly, sometimes we have to pay for funerals and pay for burials, but years later, we still work with these family members when the cameras are gone, and we still there for them. And they there to keeping their family members alive and keeping them relevant and saving other lives. That just brings joy. That's what keeps my passion going. And just to be able to help people and see them working and coming home and having jobs, it's just exciting.
The hugs and the smiles. To know that when I didn't understand the extent of this until I got married and had a kid, and you realize how much that person is a joy. And when you have the mothers and the aunts and the sisters, and they say thank you for saving my baby's life. Even if the work, Yahsef talks about it, and the work is just starting, because they are alive And because they're breathing, that means they have a fighting chance. And so we know we did something correct. And knowing, before it was kind of like, man, you're alive, but I don't know what's happening next. Now we have people to help kind of take the helm and continue the work that's been started in the emergency department and take it beyond. But I sleep a lot better because I know that we've put something in place, and I know that we have people who are more than capable of carrying this stuff out in a way that we've always imagined and dreamed of.
Mm.
I think when folks use terms like, I've never got this level of treatment before, or no one has been this helpful for me, I think those are the moments that hit me the most, because it really illustrates, like, before this, I had no one. And now I have at least a couple of people on my side to help me navigate something that I find either impossible to navigate or something that I've been reluctant to navigate. Just like James, I could come up with a couple of like random different moments in which I was like, wow, this is really the thing that I really want to do. There's a ton of instances like that where, like, this person is telling us, hey, I had no one in my corner. And now because of you guys, I have 3 to 4 people who are regularly checking up on me, regularly keeping other people accountable. You'd be surprised how many times we encounter a family where the mom and the dad is like, we don't want nothing to do with that person no more. And then we're the contact that is holding their hand as they navigate the hospital system. So it's those moments.
There's hope.
Thank you.
Mm-hmm.
Yes.
It's been really inspiring to talk to you all, to hear about your life experiences and what brought you to this work, and to hear about all the diverse programming that's happening and all that ground level community work that's happening. I wanted to thank you all for your time today.
Thank you.
Thank you.
I really want to say a big thank you to Dr. Rob Gore, Yahsef Johnson, and James Dobbins for joining me today and sharing their important work. Thanks as well to you for listening. Please remember to leave a review and subscribe. I'm Dr. Michael Shen, and this has been The Remedy, brought to you by NYC Health and Hospitals. See you next time.
This podcast was produced in partnership with Amaze Media Labs.